Beyond that, I actually believe that a lot more emphasis needs to be put on symptom management. So we know that this causes blindness, we know that it causes paralysis, but the interesting thing is that patients will tell you, patients who are blind and or paralyzed will tell you that if they could have one thing, one symptom corrected, it would be their pain. And the pain is intractable to treatment, it's severe, it's chronic, and we are not adequately treating it. We don't know how to adequately treat it. We use the types of medications we use in MS for neuropathic pain, and they're just not adequate. So probably about 50% of people who have neuropathic pain in MS are responding to these agents such that they report being pain-free. But in NMO, essentially no patients report being pain-free even on treatments. So we need to learn better about how to mix treatments and do more multimodal approaches to pain. I'm actually working on my PhD right now, and this is really a hot topic of interest for me, and I think it's been an underappreciated topic, and I think that in the next 5 years that this issue of quality of life is really going to become something that stirs a lot of interest in the field, because it's really what is at the heart of the interest for the patients. They're not a cure, no. We're not there, but that's certainly something that we're working on, and again, having that target enables us to say we potentially could have a cure for this disease in a way that you can't necessarily, I hate to say, that you can't necessarily say for multiple sclerosis, for example. But you know, there's also more going on with stem cell research. I mean, that's been a topic for decades now, but there's always evolution with that. And so it's all about, preventing and repairing, and so balancing those two things, preventing, repairing, and addressing quality of life are all the three important components of this disease, and they are really pretty rapidly evolving. So the medications that we're looking at that are being tested by the FDA, or by the three companies in hopes for FDA approval, just prevent future damage. So any damage that has already accrued isn't restored by these medications. The goal is completely just for prevention of future damage, future attacks. There are some other agents in MS. There's anti-lingo, but that really addresses myelin, and we know that NMO doesn't just attack the myelin, it attacks and kills neurons, and so it's going to definitely take bigger guns to try and solve the problem of repair in NMO, I'm sorry. It absolutely is. I feel like we have an amazing group of patients who are always so full of hope, and I'm amazed all the time at their courage in facing this diagnosis. And you can't work in NMO and not having also worked in MS, and I really am really inspired by the NMO patients, and I'm not going to make comparisons, but NMO patients are amazingly resilient people and seem to have amazing coping capacity, but again, I think that addressing coping is something that's underdone in medicine. I think that cognitive behavioral therapies, for example, attack how a person responds to pain, and those kinds of resources aren't really utilized and probably should be better utilized.